Hello, everybody. Welcome to the second week of the Fall 2023 MKRC Journal Club and Case Report. This week, we have a great presentation from student Dr. Claire Reagen. Student Dr. Reagen graduated from Rockhurst University with a BS in molecular biology. She performed the pre-med partnership with KCU, and with respect to research, she's published several manuscripts and posters to include pneumonia and hypokalemia outcomes investigated in a rural Midwestern population as a poster at the 2024 KCU Symposium, and may submit this for publication. A cadaveric case study on large condyloma with discussion of Buschke-Lowenstein tumor, a poster at AAA in Washington, D.C. at Anatomy Connected 2023 and the KCU Research Symposium in 2023. Student Dr. Reagen worked with me on a study entitled Improving Health Outcomes in Student Athletes at MSSU, a partner institution in Joplin, Missouri, and presented this poster at the 2023 Research Symposium and the Missouri Academy of Science, and we have a manuscript in preparation. Student Dr. Reagen is a member of several professional and KCU-sponsored clubs to include ACOG, AAFP, MOAPS, MAFP, as well as AMWA and the KCU Primary Care Club. Her hobbies include soccer, playing the piano, and the ukulele, pickleball, and various volunteer works in the local community through her church. Claire, it's a pleasure to welcome you to this seminar series. The stage is yours.
Thank you, Dr. Steininger, for that introduction. So as he said, my name is Claire Reagen. So I picked this topic because I'm interested in going into OBGYN, and adenomyosis is a disease that's not researched as heavily or talked about as much, but it does have a severe impact in the women who suffer from it. So this long title here is basically just saying that they did this novel procedure where they were able to keep the uterus and remove the pathologic tissue in women who were infertile due to having diffuse adenomyosis. So this was an article that came out earlier this year in 2023. I'm a fourth year here in Joplin, as said below, and I am interested in going to OBGYN residency. So I'll give you a quick interview of who I am. As Dr. Staudinger said, I am a longtime soccer player, played in college at Rockhurst. Down here are my dogs, Bella and Pepper. They're both 4 and 2. Here's my family. My brother is actually also a medical student. He's a third year in Joplin. Since it's October, here's Halloween with me and all my friends from last year. And The Office is my favorite show, so I figured that I would include a picture of Dwight and Michael as they're preparing for the watermelon birth. So moving into the introduction itself. Before we get into the actual study and what they covered, I want to give a brief overview of what adenomyosis actually is. So I know there's a lot here on the slide, so we'll cover it bit by bit, but basically the definition of adenomyosis is ectopic endometrial tissue that's within the myometrium, or the smooth muscle of the uterus. It's more common among women who have already given birth. There's 2 different types. There's one that's diffuse or scattered, which is you can see here in this presentation, and also in the study, that's what they looked at. You can also have focal if it would just be in one place, like right here, that would be focal adenomyosis. Symptoms include heavy menstrual bleeding, severe pain during periods, painful sex, and then they typically also have chronic pelvic pain in between. There can be enlarged uterine and great discomfort from this. They can diagnose it on physical exam. Ultrasound and MRI are incredibly important and help to distinguish between adenomyosis and leiomyomas, are also known as uterine fibroids. So here in America, the reliance on hysterectomy for diagnosis is still very great. And the trouble with this is we don't know the age of onset as to when the adenomyosis started. All we're able to know is that they do have adenomyosis, or did. There was an article that came out in the American Journal of Obstetrics and Gynecology in 2020, and it looked at the prevalence of adenomyosis in America. It said it was between 0.8% and 1.5%, with it being higher in women in their early 40s. So it's difficult, however, because we don't have a whole lot of information on demographics or different geographical regions to really determine the prevalence. And other studies that have attempted to do that have varied levels. There's really no consensus for how prevalent this is. So further research needs to be done, but we do know that for the women who do struggle with it, there is a significant healthcare burden. There was a study that found 82% of the women in it had to undergo hysterectomy due to their symptoms. Nearly 70% of them had suggested imaging with ultrasound and MRI that they had it, and 37.6% of those women had to be on chronic pelvic pain medications and management. Cleveland Clinic estimates that about 2 to 5% of adolescents are struggling with adenomyosis for the women who experience severe dysmenorrhea. So while we think about this as an older woman's disease, it might actually be affecting our youth as well. And this is something that we need to look into more. There's not much research that's done on the economic impact of adenomyosis, but with endometriosis being something similar, they found it's been a $1 billion market, and that the average of an endometriosis patient, their cost is about 3 times higher than their non-endometriosis counterparts. So now that I've given a brief overview of what adenomyosis specifically is, I'm going to transition into the differential diagnosis and how we would come to specifically know these symptoms are due to adenomyosis. So moving forward here, as I previously mentioned about endometriosis before, is that it's similar, but it's ectopic endometrium outside the uterus. So you can see it here on the fallopian tube, on the uterus itself, on the ovary. It can also be on the peritoneum, ureter, other places. Whereas adenomyosis is specifically within the myometrium itself. And then uterine fibroids are small, benign, smooth muscle tumors, and they can be anywhere within the uterine muscle, as you can see by the different photos. So moving forward from, here's some of the things that we have to differentiate because they have similar symptoms. We're going to talk more about adenomyosis, and since this topic affect fertility, we're going to go and dive in a little bit deeper to that. So it compromises fertility. Assisted reproductive technology, also known as ART, which is how I will be referring to it in this topic, is often needed. And like endometriosis, unfortunately, the adenomyosis tends to lower the efficacy rate of the ART. And the relationship between infertility and adenomyosis is not clearly understood. We know that it can affect uterine or endometrial receptivity, which can increase the rates of miscarriage. And it's difficult to treat infertile patients who desire uterine conservation because hysterectomy is typically the standard surgical treatment, or at least it is here in the US. But for women who want to preserve their fertility, they can't do that. Medical treatment is often transient, and they are not allowed to be on it for a very long time due to the unknown longitudinal effects of the treatment itself. So currently, there's no best consistent consensus on how do we improve fertility outcomes in these women. So getting into kind of what were some other things that they've been trying to do for adenomyosis. There have been procedures that they've done, and they found that they can reduce heavy menstrual bleeding, painful periods, and the need for hysterectomy. They've done endometrial resection, an open or laparoscopic reduction of the myometrium, and then just excising the pathologic tissue. There's been few studies out there that have reported pregnancy outcomes even after diffuse adenomyotic reduction, but this reduction is available for infertile patients to relieve their menstrual symptoms and preserve their fertility potential. So this study, what made it different is that they took those previously used methods and they modified it to debulk the diffuse adenomyosis to try to reduce obstetric complications like postpartum hemorrhage and uterine rupture, by preserving the endometrium and the normal myometrial tissue. So uterine-sparing surgery is attractive for treating adenomyosis for women who still want to have children in the future. However, there are few well-designed prospective studies on fertility and pregnancy outcomes after these surgeries. So what did this study look at, and what were the goals of the study? The primary objective of this was, does this novel method of adenomyomectomy improve pregnancy outcomes in patients who have infertility due to adenomyosis? And secondarily, does this method also improve their menstrual symptoms, specifically heavy menstrual bleeding and severe menstrual pain, via a well-designed prospective trial? So now that we've talked about kind of introducing this study and what it hopes to achieve, we're going to talk about the materials and methods and how they did it. So looking at the study participants, it was a prospective clinical trial. It was conducted from 2007 all the way to 2016. It was done in South Korea. Asian women are more likely to be diagnosed with adenomyosis, and about 95% of these surgeries are done in Asian countries. Here in America, we don't do these as much. We typically proceed with hysterectomy. So this could be something that we apply future in America and approach for treatment of adenomyosis. And they selected 50 patients based on a strict selection criteria, which we will head into right now. The first one being that diffuse adenomyosis had to be diagnosed, and it had to be diagnosed via pelvic ultrasound and MRI. These women had to be infertile for greater than a year from adenomyosis specifically, not other infertility factors. And this was determined through clinical assessment by an infertility expert. They had to have severe dysmenorrhea with a numeric scale rating of greater than or equal to 6 that was affecting their daily life. They did not specifically say what numeric rating scale they used, but typically it's a scale of 1 to 10, with 7 and above being considered severe. The next thing that they also looked at was menorrhagia, and that had to be at least 80 milliliters of blood loss by menstrual pictogram. In this study, they didn't show what specific pictogram that they used with patients. So below, I have a picture of just an example of what one would look at. So they have where you look at the clots, you look at toilets, the type of feminine hygiene products that you're using, the brands, whether it's a daytime or nighttime, and then they give you images of what it looks like. And based on that, you can determine or estimate about the amount of blood that you're losing. So furthermore, more of the selection criteria that they had was you could not have any other medical conditions with the exception of iron deficiency anemia, which is common in women who are experiencing menorrhagia. And they had to first fail medical treatment for attempted conception. Specifically, these are gonadotropin releasing hormone agonists, which I'll just refer to as GnRH agonists. And these inhibit estrogen and androgen synthesis through a negative feedback loop. Typically, GnRH is produced in a pulsatile production, but when we give these agonists, it just becomes this continuous production, which therefore inhibits LH and FSH and causes a decline in androgen and estrogen synthesis. They also had to have other infertility factors, like an ovulation disorder such as PCOS, or a blocked fallopian tubes, possibly from pelvic inflammatory disease. But the implantation failure had to be due to the disease process of adenomyosis, and they had to have at least done 2 IVF, IV embryo transfer, or ovulation induction treatments, and those had to have failed. So getting into the diagnostic imaging criteria, here's the first figure that they show. Up on the first row here, it's just 4 MRIs of different patients and their adenomyosis. The next one here is ultrasound measuring the adenomyotic lesion, which you can see around here is where they're diagnosing it on patient 4. And then this third row here is transvaginal ultrasound 3 to 6 months post-op. So getting into specifically how did they diagnose this using this imaging, they had to have a globular shaped uterus, which you can kind of see on this one here. asymmetrical thickening. They had to have hypoechogenic cystic features of the myometrium, and then a fan-shaped posterior shadowing in a regular junctional zone. You can see how they make that here. The dysmenorrhea was recorded during their last menstrual period prior to diagnosis, the menorrhagia by pictogram, and then what quantified as severe adenomyosis was it had to be a diffuse pattern, the menstrual symptoms had to disrupt daily life, and infertility, as we said before, had to be greater than a year from adenomyosis after pregnancy attempts with ART. So moving into the typical ethical approval, it was approved by their institutional review board at the hospital. They obtained written informed consent. All of their procedures were done in accordance with the appropriate guidelines, and they were registered appropriately. So getting into, they talk about they used a novel procedure. So what was the design of this? They showed a figure, and starting through here, they made a T-shaped incision, and that was made over the uterine wall, and they peeled back the serosa, or the outer layer of the uterus, to create a flap. From then on, they used an argon laser, and they shaved the myometrium back further and further, and then they created the border of the serosal flap and the residual myometrium and sutured that together. At the end, they closed the serosal flap back down and reconstructed the uterus and used a fixation suture to fix it to the underlying myometrium. So how did they get all this done? They used the initial measurement of adenomyotic lesion that they found upon ultrasound and MRI. They performed a conventional laparotomy, and then a balloon catheter was inserted into the endometrium to use the endometrial cavity as a landmark. Then they entered the peritoneal cavity and confirmed the location of the adenomyosis that they found on the imaging. And then they did a T or transverse H incision on the wall to peel and preserve the serosa for later construction. So the picture back there showed that originally they were just going for the T-shaped incision. However, there were 2 patients where they had to do this transverse H-shaped due to there being a large adenomyotic lesion in the isthmus of the uterus. What else they did was the argon laser that they used. So 2 to 3 millimeters, they shaved off multiple times and parallel to the endometrial plane. The thickness was frequently measured using an abdominal ultrasound. And they did not cut any further once they found the residual myometrium to be approximately 1 centimeter. Then they initiated reconstruction of the uterus, even if there was some adenomyotic tissue left over. They wanted to do this to preserve the integrity of the uterus to reduce further obstetrical complications in the future. So the things that they recorded, they both pre-op and post-operatively, they did 3 cycles of GnRH agonist therapy, and then they also measured the cancer antigen 125 levels. This is typically a serum marker for ovarian cancer, but it has been associated with adenomyosis, and we'll delve into that deeper when we go into the discussion. And then post-op records, just your typical operative report. They measured the weight of the resection, how long was the procedure, how much blood did the patient lose, and were there any complications. They looked at the relief of the menorrhagia and dysmenorrhea by pictogram and NRS respectively. And then they used MRI and ultrasound to confirm the remission of the disease. So moving forward into antepartum management, since this was the main goal, they had to wait 6 months before they were allowed to attempt pregnancy after surgery. And then the patients were allowed to decide whether to do naturally or to use ART. All of them were recommended to use ART, but some refused and some just ended up getting pregnant on their own. Progestin was also given to patients, and they were allowed to decide how they wanted to receive it, but it was given to every woman for up to 34 weeks of gestation to best prevent preterm birth and uterine rupture in pregnancy. So they could decide whether they wanted to administer it via a vaginal capsule every day, or they could go in and get a depot shot every week. Further moving on with the antepartum management, all of them were recommended to have C-section. Again, this lowers the chance of there being a uterine rupture peripartum. And then delivery plan was individualized by each patient, but generally they were planning to go with early term around 37 weeks gestation to be in accordance with ACOG. And then they evaluated the specific pregnancy outcomes of who did get pregnant, and out of those women, who had a miscarriage and who had a viable pregnancy. And then how many live births did they have? So with statistical analysis, how they calculated all these things is they either presented it as a mean or median. They used a t-test to compare the clinical outcomes before and after surgery. They analyzed all this with SPSS, and then 0.05 was determined to be the cutoff for the p-values for statistical significance. So we've talked about how did they do all this. Now, what did they find? Looking at patient features, looking at the age specifically, it was found to be around 35 years old, which goes kind of in agreement with the thought that adenomyosis may be typically higher in women who are older. There was a little bit of a difference, give or take 3 years. Duration of infertility was variable. All of them at least had to be greater than a year, but some women had been suffering from infertility for a much longer time. Looking at the mean weight of excised specimens, this is 94 grams, give or take 56. So again, widely variable. If you convert this into English measurements, it's about 3 ounces, give or take 2 ounces. So again, very variable. Pelvic endometriosis was found in 17 patients, or 34%. And then there were 4 post-op complications found, which you can see down here. One patient experienced pelvic infection with ureter fistula, and then POI, or down here, premature ovarian insufficiency, which happened immediately post-op. One had a subfascial hematoma, and the other had uterine shrinkage, which is diagnosed by the uterine length being less than 4 centimeters post-operatively and experiencing amenorrhea despite having sufficient ovarian function. So getting into the clinical outcomes, again, these were measured 6 months post-operatively. Dysmenorrhea was found to be significantly improved, as well as menorrhagia. And then the cancer antigen 125 levels were also found to be significantly decreased. Now looking at pregnancy, which was the primary objective, out of the 50 that enrolled, 45 of them underwent surgery, which 5 were lost to follow-up. And out of the 45 that underwent surgery, 33 of them attempted post-op pregnancy. You can see up here for some of the different reasons, but we're going to move on into the pregnancy outcomes themselves. So of the 33 who attempted, 18 were found to be able to conceive naturally or through IVF or embryo transfer. Of those 18, 8 of those women had miscarriages, 3 being ectopic and 5 being spontaneous abortions. Of the 10 viable pregnancies, they were all done by a cesarean section. There were found to be 13 live births with 2 twin pregnancies, and those are more common with fertility treatments. And 1 patient was even able to give birth successfully 2 times. Of those deliveries, there was 3 preterm deliveries. 1 was fairly preterm at 31 and 2. This was due to preterm labor and premature preterm rupture of membranes. And there were 2 elective deliveries done at late preterm at 36 and 2 and 36 and 3. So overall, it seemed that the progestin worked well to avoid preterm labor. And then there were 8 term deliveries, which were at early term with a median of 37 and 2, staying within accordance of ACOG. And then there was no peripartum uterine ruptures or need for hysterectomy, which we'll go into further in the discussion, but that was a pretty big deal compared to some of the other studies that they did. So moving into the discussion, what did this study do? They evaluated the efficacy of the debulking surgery in patients who were infertile due to severe diffuse adenomyosis. They used a novel method of fertility-preserving adenomyectomy, which increased pregnancy rates with successful outcomes. It relieved the menstrual symptoms, and it could be effective in preserving fertility in these women. Few prospective trials have been done on post-op pregnancy outcomes in women with diffuse adenomyosis, and the relationship between debulking, fertility, and pregnancy outcomes in diffuse adenomyosis is still not clearly defined nor understood. Looking at other recent prospective trials, they had quite variable pregnancy rates post-operatively, but you can see here there's a wide variety of the sample size, as well as there were varying rates of attempted pregnancy. So you can see here, it was as small as 14 up to 137. In one systemic review of 18 studies and about 1,400 infertile women, they found a 34% pregnancy post-op rate. In this study here, they found it to be 54%. All of them, as we mentioned before, were recommended to use ART. Some refused, some conceived naturally. But this study is relatively higher than the previous studies, which is remarkable given the strict selection criteria that they had to have. It's difficult to compare the results of this study directly. There was one retrospective study that we can look at to a certain extent. There was 241 IVF cycles of women, and they yielded lower pregnancy rates without surgery. This is a pretty wide range of 25% up to 40%. And then in our study here, there were no serious peripartum complications such as uterine rupture or postpartum hemorrhage. One systemic review found a 6.8% of uterine rupture in pregnant women who had undergone this fertility-sparing surgery. And just to put that in perspective, that is significantly higher than women who were not undergone the surgery. And different surgical methods could have also caused the different pregnancy rates. As in this study, they used methods that have never been used before. So what were some of those novel surgical methods that made them different? They used an argon laser over a metal scalpel, to resect the adenomyosis. And this is due to the fact that this laser has a higher cutting power and it's sharper. The wavelength is also absorbed by hemoglobin, which gave it a selective coagulability for red blood cells. And there was greater precision in minimizing the damage to the surrounding tissues, and it allowed it to maintain the surgical field more clearly. It just allowed for better margins in general. And then them also using the portable intraoperative ultrasound. They kept the myometrium at least a centimeter thick to prevent uterine rupture in future pregnancy. And then they put a balloon catheter in the endometrial cavity to provide as a landmark. Another study that they compared to, they opened the endometrial cavity to resect, and this could possibly be detrimental to preserving the endometrium and the fertility potential, whereas here it did not seem to have that sort of effect with how they did it. Looking at the new technique that they did for myometrial repair, where they sutured the boundary between the myometrium lateral border and the serosal flap. One thing to note about this is that this region does have a higher bleeding risk, but the reason why they were able to overlook this is that this flap was instrumental to removing as much as the adenomyotic tissue as they could and to reconstruct. This also helped to prevent malunion of the uterine wall and any sort of intramyometrial defect. The novel fixation suture that they used at the end minimized hematoma and seroma foundation between the residual myometrial and serosal flap. And we were able to see that this was effective with only one patient getting a subfascial hematoma. There was also one patient that got an infection, which also is another sign that it worked, as seromas are associated with greater risk of infection. So moving on to their secondary objective of what effect did this have on dysmenorrhea? So this debulking is imperative for improving the menstrual symptom dysfunction. If these symptoms persist, a lot of these women have to abandon their pursuit of pregnancy due to the fact that their pain is so great. The pelvic pain can be caused by coexisting diseases. There was a positive correlation found between the severity of the pain they experienced and the presence of endometriosis. about 38% underwent the surgery for adenomyosis and endometriosis at the same time. And the mechanism for dysmenorrhea caused by both endometriosis and adenomyosis is still unclear. There's a theory out there that this could be due to an inflammatory white blood cell response from the ectopic endometrium and the nerve fibers in the normal endometrial tissue inside the uterine cavity. But they found that the debulking is highly effective in relieving the dysmenorrhea, regardless of whether endometriosis was present or not in the patient. Looking at the complications, as we previously mentioned, we'll go into a little bit more detail, but there was a ureter fistula, premature ovarian insufficiency or POI, subfascial hematoma, and uterine shrinkage. All of these occurred in the presence of pelvic endometriosis, except the subfascial hematoma, and the pelvic adhesions seem to be a major contributor to this, which they're mostly from endometriosis or past abdominal surgeries, and they likely impacted these complications. The premature ovarian insufficiency was not likely due to the surgery itself, but due to the fact that there was decreased peri-ovarian blood supply and ovarian reservoir in general. This is possibly due to the extensive adhesion takedown that they did in these patients. And a way to get around this or decrease the risk for this in the future is patients who are high risk. It would be good to consider maybe preoperatively undergoing embryo cryopreservation. And for the ureter fistula, that was in the presence of endometriosis and infection, and this was also found when they did an extensive adhesion takedown. So further going into the discussion, both preoperatively and postoperatively, the GnRH agonist seemed to improve outcomes by lowering the inflammation caused by the endometriosis, and it reversed the adenomyosis that could be. So this allowed for conservative treatment that also allowed for a greater amount of uterine conservation. So they were able to take out as much adenomyosis as possible, and then for whatever was left, then they were able to go in and do the surgery and remove those. So post-op myometrial healing was also better due to the fact that this blocked integration of the menstrual blood into the myometrium. And one thing to note about this study is that it was done before the publication of the MUSA, but the diagnostic criteria between these two were not significantly different. The criteria for the severe adenomyosis, it's still held for all but 3 patients after the reclassification with the recent reported imaging. Now we talked about CA-125. We're going to get back into that. So it's not typically advised for follow-ups with surgery or just in general OB-GYN follow-ups, but it is vital in assessing adenomyosis treatment and recurrence. High CA-125 levels are common in adenomyosis, with a positive correlation with its development and the severity of the adenomyosis itself. The positive correlation is also found between CA-125 levels and the amount of remnant adenomyosis postoperatively, and there's typically been found to be a reduction in CA-125 levels in successful treatments. This study also supported these findings, where they found significantly decreased CA-125 levels after the surgery. And so the value of the screening to determine the elimination of adenomyosis and post-op remnant does seem to be something that should be used in the future. So getting into the comorbidities of adenomyosis, one of them, as we previously mentioned, is endometriosis, but also gynecologic cancer. These 3 likely share a similar pathogenetic mechanism. These often occur together. They share common genetic and hormonal factors, and some people will claim that these conditions are related, but still, as of yet, there's no clear or consistent conclusions about this. So further clinical and molecular research is needed on the association with these diseases, and the presence of these comorbidities should not exclude the presence of adenomyosis. And if symptoms are present, such as abnormal uterine bleeding, it's important to first exclude adenomyosis as a primary cause. So we talked about a lot of the great things that this study found, but there are some limitations, and those are important to recognize. So the first being, they said that it was difficult to select eligible patients due to the controversial nature of conducting clinical research. The timing is also an essential research task for them in the future to prevent delays that could result in permanent or further infertility, and also prevent women who could have been okay with conservative treatment from undergoing futile or harmful procedures. Another limitation was due to the fact that the sample size was relatively small with only 50 participants, and they didn't do any sort of comparative control of women who did not undergo surgery. So they're going to do future studies with a larger sample to better evaluate the efficacy of their surgical method, and they're currently planning a randomized controlled trial on the reproductive and pregnancy outcomes of infertile women with diffuse adenomyosis status post this novel method versus having no surgery. Some things that we could look at too with this being in the US would be to look at different demographics. This is all here in South Korea, so how would this be different in America where we have more diverse populations? Also, it'd be important to follow up on the recurrence of the adenomyosis in these women. It wasn't specified as to whether they were going to do that or not. So in conclusion, the first thing that they looked at was, does this improve fertility in women who are struggling with infertility? And it was found to be successful in improving the pregnancy rates and outcomes after surgery. The second thing they looked at is, does this improve dysmenorrhea and menorrhagia? And they found that it did. Also, it improved the pregnancy rates, and it preserved fertility potential in infertile women with severely diffuse adenomyosis. So that concludes this talk. I have here my references, and at this time, if you have any questions, I am happy to answer them.
Dr. Creamer, go ahead.
Yeah, thank you, student Dr. Reagen. That was a really interesting look into this research project. I was wondering if either these authors mentioned, or in your looking at some of the other literature, if they mentioned the location of the adenomyomas. I know you said it was diffuse, or they focused on these participants that had the diffuse, but if they looked specifically where the majority of the tissue was, if that had a role in achieving pregnancy following their surgery.
So they didn't seem to specify that specifically. I think when they were looking at diagnostic imaging, they mentioned finding the posterior junctional shadowing, and that's how they diagnosed it. But outside of that, there was no specific specification as to where the adenomyosis was located.
And thank you. And then my other question, towards the end, when you were talking in your limitations and conclusions, you were mentioning endometriosis as well. And I guess I was a bit confused. Were these patients diagnosed with endometriosis as well?
Some of them were. So they found that 17 of them, or 34% of them, upon the surgery for adenomyosis, they found them to have endometriosis as well. And during that time, they decided to treat them for that.
And did that seem to influence their pregnancy rate? I'm sorry, I didn't get all of that.
No, that's okay. They didn't look at that actually. They did find increased rates of complications with the endometriosis, but in regards to pregnancy, they didn't. But that would be something interesting to look at in the future, as adenomyosis and endometriosis both do affect infertility.
Thank you.
Dr. J, go ahead.
Student Dr. Reagan, that was an outstanding presentation. I mean,
Thank
that
you.
was just, you're a real pro when you came to this topic. I got in a little late, but I did see, I think, the first few slides that were your introductory slides pertinent to showing the uterus and et cetera. So my question to you is relevant to outcomes. And the timing of what to do relevant to the cycle. Does the menstrual cycle have a bearing on what time or when's an optimal time for intervention?
I don't think that they went into that. For the diagnostic criteria, they did use the most recent last menstrual period by diagnosis to determine the dysmenorrhea. And then they used the GnRH agonist before and after surgery. They did 3 cycles. So I don't know if that would have effect on their menstrual bleeding or how long some of these women were amenorrheic, but that would be something also to look at in the future.
Okay, and then also relevant to continued use of progesterone in some of these settings. When do you say enough's enough and change to something else?
I'm sorry, in regards to when they use the progestin for the prevention of preterm labor and uterine rupture,
Yes, ma'am.
they used it up to 34 weeks.
Okay, all right. Well, thank you. I really did appreciate your presentation. Well said.
Thank you.
I have a question for you. Given your stated passion for OB-GYN as a potential future career, should you succeed in getting into that line of work, is this a surgery that you would endeavor to learn? And that's one question. The other one would be, would there be an opportunity to learn such a surgery in Joplin, to your knowledge?
So currently in Joplin, there is not. I'm not sure about here in the US. I did find one study and they looked at who performed these, and about 95% of these fertility sparing surgeries are done in Asia. So it would be nice to be able to do some sort of research and see how does this affect American women, especially due to us having more different and diverse geographical regions and demographics compared to South Korea. And this would be something that I would be interested in performing or being trained in as a future OBGYN. Here in America, we don't have many great treatments for women with adenomyosis. And so this could really change the way how we treat this and help women to still be able to have babies and get their lives back in terms of not living in constant pain.
And I'll add my voice to Dr. J in saying that was an amazing presentation. The mechanics were spot on. Thank you for all your hard work in coming to this platform. Dr. Wolf, go ahead.
Yeah, I too got in late, but what I heard was also amazing. I concur. My question for you relates to the outcomes in terms of, you mentioned infection. So what does infection mean in that context? And I was curious, down the road, are these people going to be at increased rate for infection? I mean, what's the long-term prognosis of what you've done there, I guess overall, but especially with respect to infection?
Yeah, so they only had one patient who had infection, and they didn't really delve deeply into the later outcomes of these women who did have infection. In regards to diagnosis, again, they didn't say it specifically. They seem to be pretty standard, so I would assume that they would be looking at things like systemic symptoms, white blood cell count, pain, things like that. When it comes to infection, I know generally with surgery, if you've been infected before, your increases for infection in future surgeries is also increased. So that would also be something to look at if this was such a small sample size. So even though only one woman was infected, if they did that bigger, how many other women would be, and what could they do to try to prevent that.
Thanks. I was curious if anybody's looking at ureaplasma infections these days, because my reading years ago suggested that ureaplasma tended to be a rather unmeasured cause of premature labor and infections and stuff. So given that that was your interest, I was curious if you knew anything about it. I mean, OBGYN, I'm sorry.
Oh, yeah, I have not heard anything about that. But I will be looking that up after this talk.
Some of the best talks raise a lot of questions, and we got one in the chat from Marie. Was there any difference in uterine rupture rates in pregnancy after this surgery compared with other types of uterine surgery, such as previous C-sections?
So when they did other fertility sparing surgeries, they did a systemic review and they have found a 6.8% rate of uterine rupture. With just previous sections in general, there is an increased risk for uterine rupture. It depends on the style of the cesarean section, whether if it's a classic and a T or if it's your Van Steel lesion. So there's a lot of factors that play into the rates of uterine rupture post C-section. But typically, if there's not many risk factors, they do try and do a vaginal birth. Whereas in this, they considered that obstetrical complication risk to be too high. So they had all the women undergo C-sections when it was time to have their child.
Any more questions? If not, student Dr. Reagen, move forward. Amazing.
Thank you.
Great job.
Everybody,
you.
let me drop a link in the chat really quick for your future reference. The link had to change. Please refer to this for future links per se, but it's filling in. The schedule is filling in. If you click on that link and you're signed in, you will see the schedule evolve moving forward. And Grace says it was awesome, Claire.
Thanks, Grace. Thanks,
As a
Andrew.
male of the species, what I want to say is what childbirth is just a modern miracle. It's amazing that we're all here at all, that we all lived through that process, including our mothers. My goodness. So Claire, keep the passion within you. We need good doctors in that area moving forward, and you would be one for sure. Appreciate you guys.
Thank you.
Have a great rest of your week and hope to see you next week. Take care.